Hello everyone, and welcome again to Lives 2021. I will be talking about tissue oxygenation today, and this is my disclosure of conflict of interest since I will be talking about perfusion. I've done research and collaborated with a series of haemodynamic monitoring companies. But my focus when I speak about oxygenation, tissue oxygenation, is actually about tissue perfusion, first of all. And I really believe that it's important to remember that when we look at tissue perfusion, we remember that the understanding of whether there is a problem or not on tissue perfusion has to do with our clinical examination. So our cardiovascular system, our respiratory system, our renal system, they're always integrating and working as several mechanisms to keep the balance of our body. And often when there are derangement in one system, the other ones try to intervene. And our windows to try to understand if there is something occurring at this level is really the clinical examination by looking at the heart rate, the blood pressure, the skin perfusion, the mental state, the respiratory rate, and even the urine output of our patients. With all this information, we can really get a lot of important input to understand what's going on with our patient and to then start the right treatment. So it is about understanding if we can deliver really enough oxygen to the tissues. And when I mean enough oxygen, it's not just by looking at PaO2, because the PaO2 is of course important to saturate the hemoglobin. But what really matters usually is the fact that our bodies are able to have an adequate cardiac output for the needs of oxygen consumption, so that the venous return can increase and we can match the oxygen requirements in the periphery. Now, there are a series of problems, of course, with an inadequate utilization of oxygen, and so with an inadequate oxygen delivery. And if we want to keep it in a very, very simple way, just switching from an aerobic to an anaerobic metabolism, it makes a very inefficient way of transforming energy in our body. And when that occurs, it means that we will have a higher production of lactate, a higher production of carbon dioxide, and a higher production of hydrogens. Now, this is usually transferred into lactic acidosis, and to compensate this, we have some very important clinical signs that we can look at. So, for instance, the reason why respiratory rate increases very often in states of hypoperfusion, it's exactly this, because the system tries to compensate by trying to clear more carbon dioxide and to try to keep the pH in the right range. So again, to have a feeling about what's happening in the periphery, we should always start from our clinical examination. Now, what is more important? Is it the perfusion? Is it the pressure? Is it the oxygenation? Well, I really don't like to make rankings about variables. I think it's important to look at the things together. This study is very old, but I still quote it because I think it was the first study that tried to put together the concept of perfusion and the concept of blood pressure in patients with severe infections. And as you see here, I can separate patients between patients that have a good systolic blood pressure, above 90, or what I would consider good normally, and or not too low maybe, and a lactate above 4. Well, these patients, despite not being classified normally or considered severely hypotensive in the wards, well, these patients are characterized by a significant mortality, more than 10% in hospital mortality. These patients, sometimes they don't come to our attention until very late. And on the other hand, if you have patients with low lactate levels, but very low blood pressure, these patients, they also have a very significant mortality. When we combine the two situations with high lactate levels and very low blood pressure, those are those patients with septic shock. And as you see here, the mortality of these patients is very, very high. Now, If I want to oxygenate my tissues, I cannot just look at cardiac output. I need to look at perfusion as well. So the perfusion pressure also matters for the right perfusion and the right oxygenation of our patients. And that's why, again, we should always intervene very fast and try to understand not only if the cardiac output is adequate, if there are problems with perfusion, but really even if some of these problems with the perfusion may be related to hypotension or to situations in which the blood flow is not autoregulated anymore. So usually 65 millimeters of mercury are probably an adequate start, but there could be patients in which with chronic hypertension, they normally autoregulate on a higher value of mean arterial pressure. We may have to consider adding a vasopressor to these patients also to improve tissue perfusion. So individualization is important as long as you don't really go too low. If I want to complete my clinical examination, the skin is so important, the temperature and looking at the color of the skin, so mottling of the skin, for instance, is a very, very important sign to understand what's going on. And again, this as a correspondent at a basic cell level. So if I look at the microcirculation, for instance, with some cameras, I can see that there are some patients that have a good microcirculation, which is dense, is well perfused. I can see the red blood cells flowing nicely. I can imagine that the distance between cells and the capillaries is not very high, and that allows for oxygen and nutrients to flow to the cell and catabolites and carbon dioxide to be removed easily by the cells. On the other hand, when the microcirculation is dishomogeneous, I can have poorly perfused tissues, maybe the vessel density decreases and so on. So, what I can do then to get a feeling about this is not just using cameras, but just using my hands. And again, touching the patients, doing a capillary refill time maneuver. This is something very easy to do that can be standardized. And this is something that allows you to quantify also the level of tissue hypoperfusion. So skin temperature, capillary refill time, very important to add to our armamentarium of tools that we have to understand what's going on with our patients. And we even demonstrated with the Andromeda Shock randomized control trial with Glenn Hernandez, Ian Baker, that indeed by using this approach, even statistically, we could almost demonstrate a trend, and this study was initially classified as negative. The reality, you see that the peripheral perfusion approach was better in maintaining perfusion compared to a standard approach based on lactate. And indeed, in a secondary analysis published later using Bayesian statistics, actually, this approach was considered even to be superior to the standard approach. So again, I know I'm repeating myself, but the importance of clinical examination tools to diagnose and even to guide treatment in our patients. Now, we can do several tools to try to improve tissue oxygenation at the bedside. There is not a single variable that has a very high degree of specificity or sensitivity, however alone, to detect whether cardiac output is adequate or not. It is by the combination of variables together that actually we can get the best of the information. And I think it's in line with good clinical practice. You will never treat a patient just based on an echo value or on a value of blood pressure. We have to put all the information together. And the more information we put together, the better is the picture that we can get in terms of the adequacy of perfusion of our patients. Now, if I want to get a feeling of the balance between oxygen demand and oxygen delivery in the tissues, another very important stop that I can do if my patient has a central line, for instance, I do like to take a venous blood sample and to look at a central venous oxygen saturation, for instance. This formula relates to the mixed venous oxygen saturation, but the principles are basically the same. And while recent randomized control trials question the validity of protocols using SCVO2 to guide treatment, I still think that in a patient that is sick at the beginning, a check with a venous blood gas to see what the situation is very important. Those studies have demonstrated that very low, very high values of SCVO2, basically they make the SCVO2 or the SVO2 unusable, but it does not mean that when the SCVO2 is low, I should ignore this. And as you see from this very nice paper from Pierre Squarat, there are some variables that are more related in a linear way to SVO2 and other variables that are related more in an exponential way. That's why usually the SVO2 increases much more at the beginning if my cardiac output is inadequate or if my hemoglobin is low, and less later, while arterial oxygen saturation and the oxygen demand of our patients have a linear relationship with the SVO2. Why is this important? Because I can always work with, try to maintain a good oxygenation, but also part of hemodynamic therapy is also diverting oxygen where it's most needed, and I can decrease the VO2, for instance, in a patient with a severe chest infection and a high work of breathing just by sedating that patient and putting that patient to sleep. So, coming to the conclusion, to try to understand if my tissue oxygenation is adequate, I have different tools, but they all have some limitations. And when I look at SVO2, for instance, there are some limitations of the SCVO2 or the SVO2, and that's mainly due to the fact that I am taking a sample at a very central level, while this has been mixed probably by very different peripheries that could be very dishomogeneous. So in a sense, if I have something completely shunted and something that is absorbing a lot of oxygen, locally this will be very different, but when it comes close to the heart, I may detect values of SVO2 that may be perceived, may be normal. They don't take into account of the variability at more local, regional level. So the PCO2 gap in this sense is something that can come into help. The PCO2 gap is probably less blind than SVO2 to anomalies in flow and to areas of blood flow that are basically inadequate in the periphery. And what you can do is basically by taking a venous blood samples and arterial blood sample together, you can look at both. You can look at the SCVO2 first, and if this is low, then you can still work on that. And of course, you start with this if you think that your patient has a problem with perfusion, with inadequate tissue oxygenation. But if that is more than 70%, then you can start to look, for instance, at the PCO2 gap. If the PCO2 gap is low, less than 6 millimeters of mercury, then that lactate probably is something more related to cytopathic origins. And there's not much that we can do in terms of manipulating hemodynamics there. And maybe we shouldn't, because we can actually cause damage or harm. If the PCO2 gap is increased on the other end, we can try to recruit the microcirculation, again, either with fluids or with fluids and the combination of inotropes, and of course also vasopressors to keep the blood pressure at a good level. So, to conclude, tissue oxygenation is very important. Always think about perfusion. The clinical examination always comes first to understand what's going on. It's important to integrate different variables. It's really the key. And we should not miss the opportunity from blood pressure, the skin, the urine output, the mental state. And we should also add echocardiography and cardiac output monitoring in high-risk patients, and of course all those variables to look at the adequacy of perfusion, like SCVO2, SVO2, and maybe the PCO2 gap. Thank you very much.